So we are going to go on to the next talk by Dr. Nimrata Dhami, who's again a consultant cornea, cataract, and refractive services. And she is going to talk on something very interesting and different. She is going to be talking on severe pigmentary reaction with high IOP post PRK. On to you, Nimrata.
Thank you so much, ma'am. So we know that refractive surgery seems like a piece of cake, but if your moment isn't right and the cake catches fire, then that, my friends, is a real nightmare. So I'm going to share my unwanted refractive nightmare of a case of bilateral acute iris transillumination after PRK surgery. So this was a 25-year-old who came to opine for elective refractive surgery. So this is the refractive error. So we can say it's moderate myopia, compound myopic astigmatism. So his slit lamp examination and all the examination was within normal limits. There was a small nebular scar in the eye, so we decided to go in for PRK surgery in this patient. So the pentacam was also, corresponding with the clinical examination, and it was well within normal limits, so nothing abnormal so far. So we go ahead and do the routine procedure. So we use 20% alcohol to expedite the process of epithelial debridement. And again, mitomycin application, which is 10 seconds per diopter. We usually had a practice before this case that we used to pre-soak our BCL in preservative-free moxifloxacin 20 minutes before the procedure and then apply it on the cornea after the surgery, and then the routine post-operative as we go ahead and remove the bandage contact lens on day 4, and then we start the steroids. So up until day 14, it was a normal post-operative care was going on. We had removed the bandage contact lens and the patient was on routine post-operative medications of lubricants and antibiotic moxifloxacin, and steroids were started. But on day 15, the patient came back and he had a mild reaction in his right eye. There was AC cells grade 0.5 plus. And in the left eye, the reaction was more. It was grade 1 plus. So we just thought that this patient is having some secondary, the way we are tapering the steroids, so probably some inflammation is happening. So we stepped up the steroids and everything seemed to be under control. The IOPs were fine. But things kept worsening for us. And on day 16, now the patient had elevated pressure in the left eye. So now we started tablet acetazolamide and we started timolol eye drops twice a day because we thought some kind of uveitic reaction is happening and there is some elevation in the IOP. Now day 18, the worsening continues. Now right eye also has an elevated pressure and you see the left eye IOPs are off the roof. It is 42 and we added more anti-glaucoma medications and we just stepped up the steroids. We kept, enhancing and increasing our treatment. And we now ordered systemic investigations thinking that, we need to look into the uveitis or the connective tissue profile of this patient, that there must be something underlying it. And we took a physician opinion as well. So as you can see, this case happened with us in the COVID era. So we did the COVID antibodies also back then. But we see there is nothing abnormal. There's just mild elevation in WBC count, and there are IgG levels positive, serum IgG levels positive for varicella zoster virus and CMV virus, although IgG is also again significant of past infection, not current infection. So again, the nightmare did not seem to end. What looked like a normal post-operative patient has now kept worsening. Left eye, the pressure was 52. We were at the end of our wits end, like what is going to happen now? So we thought some viral element might be there, and because of those past IgG levels, we added tablet valcyclovir. And I think we spoke to everyone whom we could to find out what is happening in this patient. And nobody seemed to have a clue, and they could not suggest any more medications what needed to be given. And at 52, the epithelium also came off, and the patient was like, I cannot see anything. And it is a blinding moment in a patient who seemed like a normal post-PRK patient, was very, very uncomfortable. And we really did not sleep for those 1 or 2 weeks when this was happening. And again, Now it is 21 to 28 days. We are dealing with this patient. You can see we've added oral glycerol, tablet acetazolamide, added serum pot load, mannitol infusions are going on, but nothing seems to be working for us now. And we thought that, probably we now need to take a second opinion for this patient because now we did not know what to do. So we sent this patient for a second opinion, and we took a second opinion from PGI Chandigarh, and they delineated very beautiful properties. So this is how the eye looked. You can see the pupil is pharmacologically dilated. And you can see this is the amount of pigmentation that was going on in the eye. So these are the dense pigments in the anterior lens capsule. So these are the unique points of this case. And if you see, there is, characteristic keratic precipitates were not there. In fact, they were minimal or none. There was just pigment and pigment dispersion in the anterior chamber. And this pattern started appearing eventually, not, I think because our eyes are deeply pigmented, we did not see these defects then, but a month or two later, this photograph was taken. As we can see, there are diffuse transillumination effects which have appeared in the iris. So the gonioscopy showed hyperpigmented trabecular meshwork, and the anterior segment OCT was within normal limits. So they created a working diagnosis of bilateral acute iris transillumination, which was made by the PGI team because there was acute pigment dispersion in the anterior chamber. There were pigments on the anterior lens capsule. There was no keratic precipitates or inflammatory cells in the AC, and a glaucoma which was refractory to AGM and anti-glaucoma medications and iris transillumination defects, everything which fit into the definition of BAIT or bilateral acute iris transillumination. The other differentials were its sister concern body, bilateral acute depigmentation of iris, but the differentiation was that in those cases it is a milder variant, does not have such bad IOP spikes. The pupil distortion is not that bad as it started happening in our case, and the transillumination defects are uncommon. Next is pigment dispersion glaucoma. Although this has a chronic history and slow gradual rise of IOP and posterior iris bowing pattern, as I had discussed, that ASOCT in our case was normal, and this was a very acute presentation. Another is pseudoexfoliation, which has microfibrillary deposits or peripupillary transillumination defects not seen in our case. And another one was viral iridocyclitis. However, unilateral keratic precipitates and inflammatory cells are more matching with the picture of viral, which was unlike our case, which was very acute and bilateral and only pigment. Although glaucoma and iris atrophy fit the picture. So from where did this thing come out is that we thought, so this was the treatment modifications. Although the literature suggests that systemic moxifloxacin has been reported with BAIT or buddy cases, and now even in cataract, there are a few case reports where in cataract, after cataract and implantation of intracameral moxifloxacin at the end of surgery, they have suggested and seen buddy or BAIT cases. So we also had with topical use of moxifloxacin or the pre-soaking of the bandage contact lens with preservative-free moxifloxacin, this practice which we have now badly abandoned, was possibly the cause of this. And this is possible association of systemic is there in literature, but our case and a few other cases now I have seen have come up with topical use or intracameral use. And oral antivirals were continued, and systemic and oral steroids were gradually tapered to rule out the component of steroid responsive also. And we were at the verge of now planning a trap for the patient, but then the IV mannitol to tide over the acute crisis was done for a week, and then we saw that the IOP started, coming back to the normal range. The disease started waning off, and the patient started feeling better. So just when we were about to go into, the planning of a trap, where the pressure started coming down and the nightmare started to end, and slowly, and all the anti-glaucoma medications were stopped. So this is the course of the disease that over the next 4 months, the disease had a waxing waning course with intermittent IOP and inflammation spikes. The pigment dispersion lasted for a median duration of 4.5 months in the right and 5 months in the left eye. And the IOPs are mentioned. Now, this is the picture of the patient currently. you can see that the pupil has sustained a the pupil has sustained a dilated, distorted shape. This is the left eye. The right eye is still better. He does wear glasses. He has, sustained a good amount of glaucomatous damage, and there is a significant posterior subcapsular cataract also. However, he's still maintaining a best corrected vision of 6 by 6 with minor correction. And since last 2 years now, the patient is asymptomatic and is only on lubricating eye drops. So this is my unique case of BAID after PRK surgery.
Yes, thanks a lot, Nimrata, for showing a very rare scenario for us, and because moxifloxacin is being very often used in our practices. Now, the other thing is, since Suhasini is there, a glaucoma person, Suhasini, you know, these many of our patients who undergo laser corrections are myopes, and sometimes pigment dispersion could be associated. So, do you think we should do a routine gonio as a part of our refractive surgery screening in all our cases? And if the patient does have a lot of pigments in the angle, pigment dispersion syndrome, would you actually not take them for refractive surgery? Subhashini, you have to unmute yourself.
Quite a interesting. Yes, ma'am. Can you hear me?
Yeah.
Yeah, I have unmuted.
Yeah.
Am I audible?
Yes.
Quite an interesting case she has presented. So it's very unusual to have such a presentation. I mean, from the heading, I was also thinking of pigment dispersion syndrome. So it's not quite uncommon to get because they're all young myopes who are getting operated for refractive surgery. So there is a chance, there's a high probability of pigment dispersion syndrome in these patients, in these people, set of people who get operated by LASIK or by PRK. But actually, I was in fact thinking in terms of steroid-induced glaucoma and all that. So, but answering your question, ma'am, as a routine, actually, it would be a good idea to do because just hyperpigmentation of the trab meshwork it alone can be a finding seen in pigment dispersion syndrome. So there need not be a Krukenberg spindle, the classical findings. So it would be a good idea to do this. But in fact, I have done some 2 cases of LASIK in these eyes in pigment dispersion syndrome, and the results are no different from the others. The outcome is the same. It's not that they develop more pigment dispersion afterwards or develop high pressures. But what we need to tell these individuals is they need a longer follow-up because a subset of patients will develop pigmentary glaucoma later. So we need to, if they are on long-term follow-up, if those people go in for high pressures later. And again, the other issue is the cornea also, it's all now, the corneal thickness is reduced. So you might have misleading IOPs. So all this can make it difficult to make a diagnosis of pigmentary glaucoma later. So because your IOPs are on the lower side and you're not sure. So these kind of individuals, those with pigment dispersion syndrome, need to have a longer, need to be on long-term follow-up. But as you say, I think it's a good idea to do a routine gonioscopy in all these patients, given that they are all young myopes who get operated.
Dr. Shreyas, would you want to add anything to this very interesting case? I mean, she's discussed it all completely, all the differentials.
I had a question. Did you use a moxifloxacin soaked BCL in this case?
Yes,
Yes,
use that.
Yes.
I think
So,
that's the culprit.
That's the
That's the culprit. Yes, that's the
Yeah.
culprit.
So
Because moxifloxacin intracamerally also has been reported to cause this kind of severe dispersion
now
of
that
pigment.
now that we've reported this case, and when I was doing the literature review, because I've presented this case earlier on national platforms, and I'm just going to share an anecdote by Dr. Rajesh Kogla. He was one of the person presenting along with me, and he told me that you've got to publish this because he said that he had this similar subset in Bombay, which was, reported to him, and they said they did not do such well, photography as we did. So he asked me that you have to publish it, because this practice of using moxifloxacin in any surface ablation procedures, because the bioavailability increases. So that's what he said. That's this pre-soaking practice probably increased the bioavailability of moxifloxacin, and then we were giving it post-operatively also, because when your epithelium is going off, you still, the one thing that you don't want to remove is the antibiotic from the whole thing. And our regular practice of using moxifloxacin has been, so pertinent that, this is the one thing we did not withdraw. We reduced the steroids, we increased, systemic steroids, we did everything, but we did not do this. So this was the culprit. But I'd just like to add that, my father-in-law has been doing this. Dr. Dhami has been having this practice for 20 years. And in COVID era, we just started having this series of patients. In fact, I'm yet to publish. We have a series of 10 to 12 patients who had Buddy, the milder variant. And this was the one extreme end of the scenario, which went really haywire. So we reported this as a separate case report. So yeah, this was the culprit. Yeah, but 20 years of practice behind it, nothing happening. And then in COVID era, we had this one bad year of PRK for us in our
Also
hospital.
said that some of these patients have an underlying viral infection too. So whether
Yeah.
it is moxie as a culprit, but there is a viral etiology which has also been seen in all these patients.
Absolutely. And very interestingly, ma'am, I'd like to add this bait and buddy was first reported by a Turkish group. They had some 26 cases who introduced this term, and they kind of put all the case reports and they had this. And I found a very interesting thing that even the systemic investigations that they did, they also had IgG positive for CMV and varicella zoster virus in their patients. So in a few subset in which they found something positive, and the similar thing was in us. But again, IgG doesn't make any sense of any current infection. But I don't know, similar some viral etiology probably, or moxifloxacin doing the damage. I don't know.